All right. Hello, everybody. Good afternoon. Welcome to our December webinar for the Neonatal Initiative of GaPQC. Today, we will be talking about initiative goals and quality improvement methodology, looking towards action in 2023. And we will be starting with a couple of updates. And so I'll get into those. We let y'all know this last month, but I wanted to remind you again that quarterly reports have been posted. They're on Teams, and links were sent to the data leads for hospital teams. So they have the links to access those reports that have been posted. That's the July, August, September data. And hospitals can still enroll in active improvement or the learning collaborative. So if you've been joining and just kind of learning, but you are not officially enrolled, it's never too late. You can reach out to me. I'll make sure my email address is in the chat, or you can respond to the follow-up email I sent after the webinar. But teams can join, or if you're an individual and you want to join as the learning collaborative and not a part of a hospital team, that is wonderful too, and encouraged. So either way, you can still enroll so that you're officially counted in the initiative. Also wanted to share that the Georgia AAP's Winter Symposium is coming up in February. It is hosted together with the Georgia OBGYN Society. It is in Atlanta, and we have two members of our neonatal committee who will be speaking at the conference on breastfeeding issues. So if you are able to attend that, I'll put the information also in the chat and in the follow-up email so that you can look more into that. It's a really great agenda, some really wonderful speakers. And so we just wanted to share that information with everybody. And now we're going to move into our main part of the webinar. And we have Dr. Ravi Patel, who's a neonatal co-chair of GaPQC.
Thanks, Kimberly, and good afternoon, everyone. I'm really looking forward today to talking about kind of how can you put all the energy in starting this up and kind of move towards action in 2023. And so this is going to be kind of setting some expectations for the next year and where we hope to go and where we hope that we can bring you as our participating hospitals to. And so we're going to talk a little bit about quality improvement methodology and how you can leverage the efforts you've already been putting in, building your team, doing the monthly audits, receiving the quarterly reports. How can you actually put those now and move those into more tangible action for improvement? Some of you might already be doing this, but I think a lot of you and some of the feedback we've received are kind of what are the next steps. And so we hope really to give you some good direction over this webinar. And so the first part, I'd like to review the model for improvement, because at the core of what we're trying to do is we're trying to improve care for parents and newborns in our hospitals here in Georgia. And to do that, we need a framework, and the framework that I'm going to share is the model for improvement that I think is accessible for those of you who are doing work on the ground in your hospitals. And then we're going to set some goals for kind of early 2023 as we start to move from kind of the efforts that we've put forward on understanding where we are as baseline performance across our three measures that we're collecting in audits, giving you some guidance on content, some structure measures, really where we hope to go. And one of the goals we have, and we'll go into both of these in more detail, is we really want teams to have SMART aims by January 24th of next year. And we'll talk about that. And then we also want, as a key quality improvement tool, in addition to a SMART aim, is to have a key driver diagram that's going to list what you're thinking, what your teams are thinking of about changes they will make in next year by March of 2023. And so we're going to go into both of these, but I wanted to put these up front so you're thinking about kind of the goals that we have for you as teams as we work on this initiative. And some of you might already have this or have been talking about this, but this is really the goals we have. And so today is going to set the stage for why this is important, how we get there, and then kind of looking a little bit forward to next year. So I'm going to do a little bit of polling because I always find it's helpful in an initiative like this to get a sense for where all of you on the call are. And so if you can go to the web link here at the top, pollev.com / this is just my name, and this is just to test out if this works for kind of live polling. You can do this on your cell phone if you have one next to you or on your computer, and log in, and you can kind of use your finger or your mouse to try to peg where you hope your next vacation would be, as close as you can get it to go. Oh, Italy looks good. It's like we have a lot of world travelers on our here in Georgia. Okay, good. Well, it looks like it's working. So we'll be using the same pollev.com link as we go through, just to ask questions as we go forward. So to start, I'd like to broadly review the model for improvement. There are different quality improvement methodologies. Some of your hospitals might use Lean or Six Sigma or a combination, or the model for improvement. And there are other methodologies as well. But I think all of these methodologies are trying to achieve the same goal. And the model for improvement is the most widely used in healthcare. It's also, I think, the most accessible for teams on the ground, and it involves 7 steps. And what we're going to focus on today are steps 1 through 5. As we progress over the course of next year, we'll be talking about the last 2 steps. But really, the model for improvement starts with forming a team. And so part of enrolling in this initiative was for hospitals to submit the names of team members. And so we really started with making sure that the hospitals that were participating, particularly in the active improvement, that they actually had active improvement teams and identified the necessary components. And then number 2 is making an aim statement. And we've done that for the overall collaborative, but really one of the areas, the next kind of to do for hospitals is going to be to make your own hospital specific aim statement. Establishing measures. We have 3 measures that we're looking at in audits. And then how we can use those 3 aspects to then move towards identifying and selecting changes to test using process improvement tools. We'll talk about that. And then not just implementing those changes, but actually trying them out on small scale to see if they work, see if they need to be adapted or abandoned before you move on to larger scale testing, and eventually implementing those that you think are going to work. And we'll talk next year a lot more about testing strategies and the science behind small PDSAs that scale up. What is a PDSA? How you can actually apply it? It's often a common term that's used, but actually, how do you actually do that? And so today we're going to focus on 1 to 4. But I'd like to start with the first, which is forming a team. I think of all these changes, the most important is forming a team that's dedicated to improvement, because this is really the work of and for many of the people in our projects, this is sometimes another thing that you're doing on your already busy day. And we thank you for that effort, because this is really often quality improvement is driven by people who are passionate about improving outcomes for the patients they care for in their hospital. And so teams are important. And so one of the first questions I wanted to get from our group is, how often are you meeting with your teams? Maybe it's the people that you signed up with when you submitted your applications to GaPQC, or broader teams that are working on improvement. How often are you meeting regarding the Optimizing Newborn Nutrition initiative in your hospital? It looks so far like everybody's choosing monthly. Let's see if we get another minute or so for responses. So that's great to see. We want teams to meet at least once a month, and when we started this, we had suggested actually setting around time for your teams to meet around these webinars is a great kind of if that works with the schedule, but to at least have something where you're meeting at least at a frequency of once a month with your teams to go over quarterly reports, over potential change ideas and interventions you hope to test. And then as you start running PDSAs and changes, to actually see if they're making the difference you intend to, and whether you'd like to keep them going and implement them, or whether you need to think about other changes. So that's great. And as always, it's great to celebrate the successes and wins of your teams as you do this work, because a lot of quality improvement efforts and team work is really driven by people who are incredibly motivated to really help improve the outcomes of the patients that they're caring for. So the second and third steps in the model for improvement are making an aim statement and establishing measures. And these seem like very straightforward and simple, obvious things to do, but these are really fundamental in really improvement science and methodology. And so I wanted to start by seeing from our hospital members, do your teams have you already developed a SMART aim for this initiative? We have one for the broader Georgia Quality Collaborative, but for the hospitals itself, have you already developed SMART aims? Okay, so it looks like about a third of you already have SMART aims. So that's great, and we're looking forward to learning what those are. For the rest, that the rest of the 2/3 of the GaPQC, what we'd like to see by January is that January 24th is we move to where A is getting close to 100%, and so that's one of the goals we have, is to actually have all of the teams that are in our active improvement group having SMART aims that they've drafted. Doesn't mean they can't be modified or adjusted as time goes along, but we want to see that. Why is that important? Well, if you think of the kind of simple model for improvement methodology, it really asks three questions. The first is, what are we trying to accomplish? The second is, how will we know that a change is an improvement? And the third is that what changes can we make that will result in improvement? And we know from a number of examples that if you can put these three questions, and finally for the last one, what changes can we make that result in improvement, and actually test those out in PDSA cycles, that you can actually achieve remarkable improvement. It can sometimes take time, and it sometimes takes a lot of testing, but over and over again, many groups have shown actually the ability to improve care through this approach. So the first is really, what are we trying to accomplish? This is where your SMART aim comes into place. And so for us as the GaPQC, and you've seen this on our monthly webinars, what our SMART aim is, which is that we want to increase the percent of newborns in our GaPQC hospitals with human milk as a first feeding by 10%, from a baseline, which we derive from the first three quarterly reports of 73%. We want that to go up to 80% or greater by the end of this effort, which will be in September of 2024. So that's our SMART aim. And we'll talk about how actually hospitals might use the data from the most recent quarterly report to help refine and guide their SMART aims. Now, second is, how will we know that a change is an improvement? And this is where measurement is critical. You can make changes, but what you really at the end of the day want to know is, are you actually improving? And that might mean that it's not just the policy or just the education that's sufficient, that you really have to test whether those changes are actually really leading to improvement. And so one of the things you've already been doing, and that's really been core for this initiative, is measuring and doing monthly audits. And we've really want to thank you for your efforts in doing this. We've had really great engagement in having these completed. And these monthly audits are measuring 3 critical measures as it relates to newborn nutrition. The first, which is tied to our overall SMART aim, which is human milk as a first feeding. Number 2 is formula supplementation last week. And the number 3 for most of our hospitals is timeliness of breastfeeding expression, but may not be applicable to all settings. And so these 3 measures are really to give you data, actually very rapid data of how you were doing last month on these aspects of newborn nutrition in your unit, whether that's the NICU setting or the well newborn setting. And so this is already something that you're doing, and I think it's critical. I know it's a lot of effort to do this month in, but this really is the best snapshot you can get of how you're doing. So this is our first 3 months of our audits that we did, and this gave us a sense at the state level. We don't have this data anywhere else of how we're doing. And so this is where we established our baseline of about 73% in our GaPQC hospitals receive human milk as a first feeding. And we think there's room for improvement. And our goal, as I shared, is to get this over the course of the next couple of years to get it above 80%. And that's where we hope to go. That's going to be a 10% increase. And we're going to rely on all the improvements that you as our teams are making to achieve that. And that's going to involve changing. We know this is actually relatively stable month to month across our hospitals. So we know, the current processes and care that's being provided is designed to achieve about a 73% human milk as first feeding rate in our hospitals. And so if we want to get that higher, we have to think about what are we going to change from what we're doing currently to achieve that. And so this is for the GaPQC. This is our data that's informed our SMART aim. And so thank you for that. Now, what we want to do is really to have hospitals themselves, each of the hospitals, start to think of what are going to be the hospital-specific SMART aims. And these might be different than the GaPQC SMART aims. And this is something that we'd like our hospitals to submit to Kimberly by January 24th of next year. And so what can you use to guide these SMART aims? So for those of you that have looked at the quarterly reports, you've seen that there's a box at the top of those quarterly reports that's blank, and that's really where we want these SMART aims to be included. Because that's really the first question that the model for improvement asks is, what are we trying to accomplish? And it's important to get that on paper, to quantify it, to have an end date, and actually a quantifiable, achievable measure. We've talked about SMART aims before, so I'm not going to go through in detail about that, but I do think that it's important for us now to get these on paper so that by the time we send our next quarterly reports, that we'll be able to, ideally by then or the following one, have your hospital SMART aims at the top of that. So these are actually 3 examples of actual reports that were sent to 3 of our participating hospitals. We've de-identified them as Hospital A, Hospital B, and Hospital C, but this is what the reports look like that you've received already. This is what we said in return for being able to collect data. We can give you a snapshot of how you're doing. And each of these reports have a box here where we'd like to see the SMART aims included. The next time you see that, so you can tie these measures to what you're working on. These might be different for each of these 3 hospitals. And so what I'm going to show you is kind of how you can use these quarterly reports to inform where you want to work in terms of your aims and the measures. But first, I'd like to actually ask, for your hospitals, who has your GaPQC quarterly report been shared with? Anyone? And if it has been shared, who has it been shared with? So we'd want to know, how are you sharing these data on how you're doing with in newborn nutrition with the people in your hospitals? So you can see a diversity of responses here. And this is, who is the right audience for these reports? I think that's really up to your local hospital context. But one of the quality improvement principles is bringing visibility to the system, making the system visible. And I think part of that is actually making it visible to the clinicians working in your hospitals about how you're doing with this. And so it might be, option D, where these data are shared with all staff, might be an opportunity to give an idea of how your hospital is doing. It's important to share the methodology and they understand what you're measuring, and or it might be option C or B might be appropriate. But I would say we would like to see those that haven't shared it, that this is really an important effort for the time you're putting in to really make it visible about how are you doing. It's a great way to kind of brainstorm improvement, is to share your report and to have it be a conversation about how things are going in terms of your setting, whether that's in the newborn or the NICU. Take time to share this data. That's one of the reasons we're collecting it. One of the reasons we're giving you these reports back is to really be a tool that you can use to stimulate improvement. So how would that work? How would these data be used? And so one of the things, when you look at these, are all from our last quarterly report, 3 different of our GaPQC participating hospitals, all blinded here. And these are just for examples that to give you a sense of, how can these data be used? So these are two hospitals that are in the NICU setting, one that's a newborn. And what we looked at is the baseline performance. So the first 3 months of the audits, quarterly audits, taking the median, which means taking the middle value. You could also just take those 3 numbers and divide them by 3, and that gives you an average. That's also okay. Either approach to get a sense of how you're doing. And so you can see for hospital A, if you're looking at kind of their measures, you might say, for hospital A, this human milk as a first feeding might be a good target. That's currently at 40% of their infants in the neonatal unit are getting human milk as their first feeding. So there's room for improvement. Hospital B is doing pretty well with human milk as a first feeding. 90% of infants are receiving human milk as a first feeding. So maybe this hospital might actually see opportunity in formula supplementation, potentially, if it's appropriate, reducing inappropriate formula supplementation, or to look at breastfeeding timeliness or breastfeeding or expression. And hospital C is really doing very well with human milk as the first feeding, is doing well with breastfeeding expression within 6 hours. And so really the opportunity here might be really focused, if you look at this, on formula supplementation in the last week. And so these are the types of data when you can share, have conversation about, this is how we're doing. It's good to look over 3 months, and the reason we wanted 3 months of data, so you get some sense of how stable these measures are over time, to get an idea of your baseline. And so that's the rationale behind these quarterly reports, to get a sense of how you're doing. And these are 3 of our hospitals here in Georgia, and how we're doing with our measures. And each of these 3 could then lead to potential smart aims. So these are suggestions that if I was looking at this data that I might think, but these are the types of discussions you should have with your teams, your stakeholders. Hospital A might aim, based on their to increase human milk as a first feeding, maybe a little different than where the GaPQC is. The GaPQC's baseline is 73%. That's kind of the average for our state, but here, trying to get in close to kind of the benchmark of the GaPQC from 40 to 60%, maybe even higher. Hospital B might aim to increase the timeliness of breastfeeding or expression within 6 hours, from 30 to 50%. And hospital C might aim to decrease formula supplementation from 40% to 30%, or maybe even greater, to 20%. There might be some infants that there are going to be some where it's medically appropriate for formula supplementation, but maybe there's an opportunity here to reduce formula supplementation. So this is how we hope that these quarterly reports, we hope that these are useful. We encourage you to share this with your teams, to have discussions. I know I've received, we've had from our context of hospitals, these measures, and there are some hospitals that are building on these and adding additional measures, and that's great. To use this to kind of set your smart aims And these are just examples. These aren't the ones that hospitals have to choose, but this is how I think these data could be used. And using the first quarterly report as your baseline, that's where you're starting. Now, where you set your goal, that's really up to your teams of where you want to go. We looked at the state as a 10% increase, but you might aim for more than that, and that's a discussion that you should have with your teams. And as you go through the initiative, as we continue to measure, we'll be able to see, and you'll be able to see, are you making progress towards these aims? So the next, as you make your aim statement, now you have an idea of what are you trying to improve. And you can answer, how will we know a change is an improvement? Because you're measuring. So you'll know if you make changes, whether it's improvement.
Data collection.
Could I ask whoever's on to please mute? The next part now is actually to actually make improvements. And if you believe that your current outcomes, the current outcomes that you're seeing in your quality report are reflective of the current care that's being provided in your hospitals, and if you want to change that, that's going to require some change in your process. And the goal is to identify and select changes to test using process improvement tools. And there are a number of different process improvement tools. We'll touch on some of these as we go through the initiative. But these are the tools that can then help you to then decide what are the things that you're going to try out and change using PDSA cycles. Eventually, you want to implement those changes that work and not abandon or not implement the ones that don't work, that might not work. And finally, there's an opportunity to spread these to other locations. And this is where collaboratives such as ours are great opportunities to share and learn from other teams. We had an example of that just recently of changes that other hospitals are implementing that might be opportunities to spread to other locations. So what about number 4 and 5? Well, in the model for improvement, if you want to think about what changes can we make that will result in improvement, you really need to be thinking about process improvement tools. What are the tools we can use to identify changes to make that will result in improvement? And then you want to test these changes out. And so the two kind of process improvement tools, and I'll say the most important that we want teams to develop and consider, and this is going to be a process that might require a key driver diagram that's refined, is really to get on paper or on a PowerPoint or another document a key driver diagram about changes that you would like to consider potentially testing in this initiative. And so thinking, and I'll talk a little bit about that. And then one of the other tools, this is really tied to the measure, is run charts. That's another improvement tool, but this is something that we are you're able to do this on your own, but quarterly we're giving you reports that give you a sense of how you're doing on run charts, and you just saw a few examples of that. There are other process improvement tools we'll talk about. How do you decide what's feasible? And there are different ways of brainstorming techniques, and we'll as well as more advanced tools. But the most important single tool that you can have in addition to your smart aim is a key driver diagram. And so we really are aiming for, by March of next year, March 1st, we want hospitals to have key driver diagrams in place. So the question I have for our teams is, do you already have a key driver diagram for your hospital? You've seen the one we have for the GaPQC. That's a little bit overwhelming, but have you actually developed one for your hospital? So this is right where we should be. We are working on our baseline data. Our next goal is our smart aim, and what we hope is that we start to shift to where we start to see more yeses over next year. That's one of, moving to action. One of the key components is going to be developing a key driver diagram for your hospital. And so what we like to see is starting to see that key driver diagram it's a living diagram. So it is some that's going to change. And as you go through your initiative and learn, you might add things to that. You might change things, but that is really a framework for what your overall strategy and theory is around improvement. So you've seen this on our monthly webinars. This is really to give us kind of a broad structure from the level of view of the overall collaborative on the aspects we're hoping to do. And what we designed the key driver diagram is really to put a context and a strategy for how are we going to achieve our SMART aim. So the key driver diagram on the leftmost box usually has the SMART aim. You've seen this is our GaPQC SMART aim. You've seen examples of potential SMART aims for hospitals based on using their quarterly reports. That could be really the primary measure, which is human locus of first feeding. You might have SMART aims related to the other measures that you're capturing on audits. Or it might even be another measure that's not something that we have as our standard audit that you might be collecting that's tied to your measure. But this SMART aim should have a baseline where you hope to achieve and by when. And really our global aim, and I think this is shared across all of our hospitals, is to improve breastfeeding outcomes for babies and mother in our Georgia hospitals. Now, the drivers of this SMART aim, what are the factors that are influencing the success of this SMART aim? And so these are some of the what we think are the key primary drivers. And there are a number of potential interventions that might address this. And these would be considered changes, potential changes related to these interventions that might influence these drivers that might lead to improvement. Now, these are going to differ by the hospitals in the context. Some of these might already be routine in your hospital. Some of these might not be applicable in your particular care setting. But these are the kind of interventions that we started for our initiative off. And so our goal has been to try to build in webinars that tie and give you ideas and knowledge and the evidence around some of the potential interventions that might influence these drivers and SMART aims. But we don't expect you to do all of this. So what we realize this can be overwhelming when you look at this key driver diagram. And so as a hospital, what you're really going to be thinking about is paring this down. And so I'm giving you an example here of that hospital B, the one that you saw the quarterly report on. This is what a hospital B SMART aim might be. And so this might be a hospital that really wants to try to improve the timeliness of breastfeeding or expression. They use the quarterly report to guide their baseline. Now, for this SMART aim of timeliness of breastfeeding expression, there might be only a few key drivers that influence this. And you might add more, you might revise this. This is really based on your team's thinking about what are the reasons why only 30% of the patients, the babies in our NICU or their mothers are breastfeeding or expressing breast milk within 6 hours. What are the reasons that it's only 30%? Well, it might be that they don't have early initiation of breastfeeding or milk expression. Maybe that there's a issue with kind of the ability of the staff to assist with breastfeeding or awareness of the mechanics of lactation breastfeeding that might influence this. And then there's potential interventions to address these drivers that might lead from prenatal breastfeeding education, postnatal education. Maybe it's also newborn separation has an influence, or the need for lactation consultation. These potential interventions may or may not be right for your setting. And so one of the things that is helpful for your hospitals as you develop these driver diagrams is to think about, kind of the list, and you can be expansive on what are the things you might try to make changes. You may not select all of these, but it's good to write down potential changes that you think might influence your drivers and your aim. Our goal for the monthly webinars is to give you ideas on the data behind these potential changes. And from these, you can then select what are the ones that might have the most enthusiasm in your units, might be ones you haven't already tried or aren't already doing. These might be the most feasible in the context of your particular setting that may be less or more feasible at different hospitals. And maybe there's an opportunity for shared learning. So the hospital that has a 90% rate of breastfeeding or expression within 6 hours might help give some of the ideas of what they're doing that can help. And maybe this is very context specific, whether it's the neonatal intensive care unit or whether it's mother baby. Here's another key driver diagram. This is for hospital C. So this is a hospital that already, if you remember, had 90% breastfeeding initial feeding with human milk, 90% of breastfeeding expressed within 6 hours, but about 40% of infants were receiving formula supplementation. So there might be an opportunity to reduce formula supplementation from 40 to 30%. That might be greater if the hospitals decide. And so in the key driver diagram on the left box, there should be your SMART aim. That's always where the key driver diagram starts. What are the reasons that 40% of newborns on average every week or every month are getting formula supplementation? I think that's part of understanding your context. What are the reasons? You might, when you're doing audits, start tallying what are the reasons that might that babies got supplemented with formula. Maybe it was hypoglycemia. Maybe it was the lack of early initiation of breastfeeding or milk expression. Maybe it was the lack of ability of having human milk alternatives when mother's own milk was unavailable. These are all the reasons that might influence why 40% of infants in hospital C are getting formula supplementation. Some of them might be perfectly appropriate and medically indicated. And so it might not be that 0 is the right goal, but 30%, reducing it by 30% to 30% or maybe 20%. What are the potential interventions that might address this? And this is where there are change ideas. You can make a list of what are the potential interventions that you might try. It might be that for formula supplementation, potentially having a human milk alternative might be a potential intervention that might involve donor human milk, but maybe it's just not feasible. That's something that might be a long process, and maybe at the time that's something that you're considering. But maybe the potential intervention is changing feeding regimen protocol so that newborns with hypoglycemia, instead of getting formula, they get glucose gel, and that's the intervention that you're going to work on and focus on is a new protocol that ties to indications for formula supplementation, and that instead of formula supplementation for hypoglycemia, there's administration of glucose gel. And so this is how I think hospital C can consider their theory on what are the changes that we need to make to improve. It's important to be honest about quality improvement, that it's not always the changes you think aren't always going to work. And that's where measurement is really critical, because at the end of the day, what you're going to be looking towards is, are you actually moving the needle on the measures that you're looking at, that you're getting from your monthly audits? And if you're not, you have to come back to your key driver diagram and say, what other driver do we need to address that we're not addressing? We've already addressed one, but it didn't seem to have the effect. What else do we need to do? And maybe what other potential interventions do we need to consider? And maybe this list gets expanded and you select additional interventions over time. And this is the way it's helpful to have this as your theory or your kind of broad strategy of why you think 40% of infants in your unit are receiving formula. What are the reasons for that? How can we address those with changes or interventions? And maybe selecting those. And you might only select a couple. You might start with just one. And over time, this is a living document. You can refine this as you learn more about the reasons for why 40% of infants are receiving formula. Maybe as you listen to webinars and you get more ideas about potential interventions, you start to add these and choose these. And really our goals over our educational webinars are really to give you ideas of potential interventions and change ideas that are evidence-based, that are going to support your aims. But we really rely on you to help decide what are the ones that you're going to choose to test and change. And that might involve small tests, and that's what we're really going to focus next year on, is how do you then, once you think of these interventions, how do you actually test them out to see if they're working and eventually implement them, put them into policies and guidelines and improve. So our goals of monthly webinars are really to give teams change ideas. We also think this is a great opportunity to share change ideas. And as they relate to changes, what are the changes we can make? That also comes along with what are the policies that you have, the written policies. Those are great to be able to share amongst hospitals and adapt to your own hospital. What are the policies that you might have? In the last example, do you have a glucose gel protocol for neonatal hypoglycemia. That's something we're thinking of. You have the benefit of an audience of a number of hospitals that can share those that you can see, so you don't have to do it yourself. And those are the things that we hope we'll be able to do. And that's just one example, and there are many examples like that. But as you think about this, and you're meeting with your teams monthly, as you start, one of the first goals we have is a SMART aim by January 24th. And then we really want in the first quarter of next year to really be starting to think about what are the changes that we can make that will result in improvement. What are the changes in your hospital that you're thinking address the drivers that are going to lead to improvement? And as part of that, I think it's really critical to have a key driver diagram on paper that we want to see. And so we're going to, by March, we want that key driver diagram from our active improvement teams, and that key driver diagram will have a SMART aim and we'll have an idea of what you're thinking of changing, and we will provide feedback on that as well. And our breastfeeding and nutrition experts will also be able to look at that and give you some ideas. And we hope that can really be a framework. So as you meet with your teams, you say, okay, look, we've worked on this driver diagram, we've done these interventions, we still have, and maybe that's what you need to do to achieve success. Maybe there are other things that you can do. And I think what you learn in this methodology, we hope that this is applicable to improving newborn nutrition, but really can be tools that are applicable to any improvement process or improvement project that you decide to take on in the future in your setting. And so what the methodology that we're showing, while it's specific to this GaPQC project, we really want this to be important and relevant for any improvement project that you hope to take on. And then we're going to talk a lot about testing and how can we, once you have these ideas, instead of just doing a broad scale implementation, how can we test to kind of refine this to make it, make sure that it actually achieves what we hope, and ideally doing that on small scale before implementing it broadly. And so we'll talk about PDSA cycles and strategies for that. This is challenging to do PDSA cycles in rapid form. It is a challenge. And so this is one where each hospital might have different ways in which they apply PDSA cycles. But this is something that we're going to focus on once we get you to SMART aims and key driver diagrams, which are the next two steps. And so if we think of kind of where we're going to go, the title of this was Looking Forward to 2023. Really what we want is to thank you for continuing the monthly audits. That's really important for us to measure. Getting a SMART aim with your teams, meeting with your teams and having that. We have about a month and a half to get your SMART aims, 6 weeks. We think that's ample amount of time to really think about SMART aims, getting a paper, sharing it with us. And then we'll come back to this as well, but really to think about your key driver diagram. This can be done on paper. We're going to share a template with you, so you can edit a PowerPoint slide. This can also just be written on paper initially and shared. And then we'll be talking more about changes in PDSA cycles. So I hope this gives you an overview, a little bit more tangible specifics of what your team should be doing as we go into 2023. We started with really getting this launched, forming teams. You've done audits. We have a sense of how your baseline is, how you're doing in these three measures. Next, we're going to move to SMART aims, and then what are the changes we can make to impact your SMART aims. We'll share a template of a key driver diagram that you've seen, and you can edit that and as you need. We're here to help in terms of helping your teams refine that and giving you input. And we'll talk more about this next year, but really as we've learned from our Vaughan Centers of Excellence, and we had a number of centers in Georgia that achieved Centers of Excellence for our last improvement project focused on neonatal opioid withdrawal syndrome or neonatal abstinence syndrome. Achieving these two and meeting these two milestones, goals 1 and 2, are really going to be important for our hospitals here to be recognized as GaPQC Centers of Excellence. And I think we have great teams, and so we're here to support you. But we do want to see movement on these two goals. And so with that, I'm going to finish with just the last question, which is, if you have ideas of topics you'd like us to cover in 2023, you can just free text these in here and we can collate them, and then I'll leave it open for questions.
Thanks so much, Dr. Patel. We do have a few more minutes so we have time for questions. There is a question in the chat thinking about building a team, and it says, any tips for folks who need support on establishing a team that is invested, not just names on a list?
Yeah, this is a challenge, and I think it's always good. You know, the way I think of, if you had to pick 3 people on a team, the goal is kind of the head, the hand, and the heart. What I mean by that is the hand is somebody who's going to be able to kind of do the work on a day-to-day basis, and that might be who is able to do your measurement and do your audits. The hand is one person on your team. The head is one person on your team that might have some ability for quality improvement methodology that might help with developing or knowledge expertise, developing your key driver diagram. One of the benefits of being part of the GaPQC is we also are here to support you. We are part of your teams, and our goals are to help you with that as well. And so that part of that kind of head in terms of this, the science and the knowledge base of nutrition and breastfeeding, we have a lot of expertise here. We've partnered with Claire Eden and Dr. Fairley, who are experts in this area for kind of expertise in that aspect. And the last is the heart, and the heart is somebody who people look to in your unit and trust that is going to be able to build support, and finding and kind of building that person on your team. It is a challenge. You know, staffing is challenging. These are difficult times. One of the ways, there are a few tools you can use. One of the ways is to share your data and just have a conversation, you know, saying, you know, this is how we're doing. How do you think we're doing? That can sometimes allow some reflection on, this is our last quarterly report, and are we doing like we wish we were doing? So sharing data can be a powerful motivator because it's objective and it tells you how you're actually doing in your hospital. Sometimes if it needs more support, you know, one of the things, these are key measures that hospitals are judged against is to bring it back and share the report with hospital leadership to see if they can invest effort or time of people in there. It is a challenge, and sometimes it's slowly working on and finding what's opportunity. So I hope that's helpful. I share your challenge. It's not always easy. If you don't have a team that you can't, you know, there are certain times where if the team isn't able to, the team you started this project off with isn't meeting the needs, you can always reconsider kind of who needs to be in that team. And maybe if it's a newborn provider, maybe it needs to be an obstetric provider that you need to reach out to, or somebody else that might be there. And so there's always a chance to kind of reconfigure from where you started off and signed up for this initiative. So those would be the suggestions I would have.
Any other questions? If you're thinking of final questions, I have a couple more things to share. Just some important dates to remember. After everyone has a happy and healthy new year, we'll reconvene in January for our January webinar. On the 10th, it will be about lactation risk assessment and the warm handoff. So we look forward to seeing everyone then. And a reminder to data leads that the audit will go out December 26th. That's a Monday. You will have extra time to complete the audit, just like we gave for the Thanksgiving week. We gave until that following Wednesday instead of cutting off on Friday. We'll also allow that extra time because we know the holidays are a very busy time. And a reminder to that Smart Aim, you can email it to me by January 24th. My email address is there. And of course, reach out with any questions you have about anything. And if I don't know the answer, of course, I'll get you to one of our experts who will be able to assist with any questions you may have. If there are no other questions, so we are done for the day. Thank you, everyone, for your time. There is a reminder in the chat, registration will open soon for the annual Emory Breastfeeding Conference, March 13th and 14th in person in Atlanta. And yes, Deborah asked about further information on the February meeting in Atlanta. I will send that in the follow-up email. I'll send the link to all the information along with the agenda so you can see what that meeting will look like. All right, thank you, everybody. Have a great afternoon.